Good evening. I would like to make a start with the rest of the evening, and I would like to start to acknowledge the Tasmanian Aboriginal people as the traditional owners and ongoing custodians of the land on which we are meeting today, and I pay my respect to elders past and present, and I would also like to acknowledge Aboriginal people who are with us today. Primary Health Tasmania would like to welcome you to this special event, which is part of our suicide prevention lifespan trial. Tasmania is one of the 12 sites around the country taking part in this Australian government-funded trial that's aimed at testing new approaches to helping communities reduce suicide. Tasmania adopted the Black Dog Institute's lifespan suicide prevention model for the trial, which combines 9 evidence-based strategies into one community-led approach. The trial is run in 3 local government areas, Breakaday, Launceston and the Northwest, which includes the Central Coast, Burnie and the Devonport councils. And the City of Launceston is the host organisation here in Launceston, and they are also hosting an event tomorrow with Professor Draper at the Tram Sheds, which is more focused on community. It's a 3-year trial that started in 2017 and is going to finish up in June 2020. And the target populations are men aged 40 to 64 and men and women over the age of 64. And so we're very pleased to have Professor Brian Draper here with us today. Professor Draper is a psychiatrist and conjoint professor at the School of Psychiatry at the University of New South Wales, and a member of the Lifespan Research and Advisory Committee. Professor Draper is an expert on later life suicide prevention and presented at the 2018 Tasmanian Suicide Prevention Community Network Forum that was here in Launceston. And we received a lot of interest in Professor Draper's work following this event, hence this event here tonight. So the purpose of this forum is to build the capacity of health professionals by increasing their knowledge about depression, anxiety, and suicidality in old age. And I'd like to mention that in addition to this, Primary Health Tasmania is also working with peak GP bodies to improve the capability and capacity of GPs to manage suicidality. We're also working with the Black Dog Institute and peak pharmacy organisations to develop a customized training program for pharmacy and pharmacy staff in supporting people at risk of suicide. Now, this event is being sound recorded through this microphone and the microphone that Professor Draper is carrying. So we will have a question and answer session after Professor Draper's presentation, and so we'll need to use this microphone. But if you do not wish to be wanting to be recorded, please raise your hand now, and then we'll avoid recording your voice on this sound recording. Everyone okay with being recorded? The recording will be available on our website, and we will email you the details of that. Okay, I'll hand over to you now, Professor Draper.
Yeah, thank you, Liz, and the Primary Health Network for bringing me down here today. And I'm here for next week, which I'm looking forward to a lot. So I've been asked to talk about depression and anxiety in old age for this presentation, but as we heard this Q&A afterwards, we can go into other related topics. That's up to where your questions take you, I guess. And happy to do that and be pretty sort of broad in taking whatever questions are of interest to you today. So this is basically what I'll be talking about. And so I want to just talk very basically about what depression and anxiety are in older people, some of the risk factors, issues about recognition and treatments, and how that with appropriate treatments, a lot of effectiveness can be found. So to start with, just to get to the basics, I guess, what is an anxiety disorder? Because we all feel a bit anxious at different times. I mean, I was asked before I started, do I get anxious before these talks? Well, Not so much anymore. A nice glass of wine helps, but it's normal to get a bit anxious about things. That's all of us get that. That's how we get through life, really. And but it's when it gets beyond that, of course, it's become something that's disabling and causes quite severe disruption to many people's lives. So it's when those symptoms of anxiety are pervasive and interfere with your sense of well-being. That's really when we get into the area of it being a disorder. And there are lots of types of anxiety disorders. I've listed there post-traumatic stress disorder, of course, agoraphobic disorders, generalised anxiety, just to name a few. And of course, some people get specific phobias, about things like spiders or snakes or stuff like that. Anxiety, just like depression, has a lot of physical and psychological aspects to it in terms of symptoms. So, you can have some patients who present to you who are very anxious and their symptoms are mainly physical, and there might be persistent diarrhea or persistent problems with other aspects of their bowels, or some aspects of irritable bowel syndrome at times can have a lot of anxiety components to it, for example. So there's that aspect. But of course, most frequently, people will speak to you specifically about how they feel, panicky symptoms and so forth. Anxiety disorders do diminish with age. And this is from 2007 data. And I think the first thing to note is the age at which they start to go down. That's around midlife, really, around the age of 50, not in late life. So it's certainly true that middle-aged and older people are much less likely to be anxious than younger people. So the turning that around, if your older patient starts talking about being anxious, they've never really been that before, or they observe to be anxious, it's often, you've got to start asking yourself, why is that happening? Because that's not normal for that to happen. People don't usually start getting anxious if they haven't been so early in life, and there's something else that's going on. And it might be a medical problem, it might be a cognitive problem, it might be many other things. So that's worth bearing in mind. The other thing is that although that data is essentially correct in terms of the pattern, the extent to which the anxiety disorders go down is probably a lot less than that, because I think the nature of the way the methodology of the study that got that data was a little bit incorrect, if you like. I could mention that later if you like. If people get anxious and depressed together, which is quite common, then that's a much more difficult to treat situation for both the anxiety and the depression. And many people will have both. Many people have that comorbidity. And so over 50% of people with clinical depression have some anxiety symptoms, and about a quarter of the people who have an anxiety disorder will have significant depressive symptoms. So it goes both ways. And a study that I was involved with Osvaldo Almeida, who's based in West Australia, which was a general practice-based study, we found that people who had both disorders over a 2-year period had a much more chronic course than people who had one or the other disorder. So it adds to chronicity and adds to treatment resistance. So there are two main reasons that an older person might develop anxiety for the first time. There are many other reasons, but the two main ones: fear of falling. So one of your commonest scenarios in late life is the older patient who gets fears they're going to fall over. They might have had one fall, but that it gets generalised that they're going to have many other falls, and it leads to them restricting their lifestyle considerably. We found that people with somewhat anxious personalities pre-morbidly are more likely to develop that, so more neurotic style of personality, if you like. And that will tend to happen sometimes in people who start to have some cognitive decline. So we find that people in the early stages of cognitive change are more likely to start showing an increase in neurotic and anxiety symptoms. So that we've certainly got longitudinal studies that we've done that have shown that. And of course, then an outcome of fear of falling and fear of going out becomes agoraphobia. So in late life, agoraphobia, unlike in early life, agoraphobia is a reaction to panic disorder. People have panic disorder and become agoraphobic. In late life, people are usually not panicked, don't usually have a panic disorder. It's usually a fear that something will happen, such as they'll have a fall or they'll have a stroke or something along those lines. And in fact, one of the reasons that data I showed you earlier with the graph going down was so steep is that in the way that study was done, if you had a physical explanation for your symptoms, it wasn't counted as a mental disorder. So an older person who said, well, I'm a bit worried because I might fall, that wasn't counted as a mental. So these got undercounted. It's one of the reasons that happened in that research. There are other reasons, but that was one of them. And of course, people who are agoraphobic often get depressed. I mean, if you're agoraphobic, you're an older person, you don't get out, you're socially isolated, and social isolation, I'll talk about a bit later, is one of the main reasons for depression happening. So this is why that comorbidity tends to happen, one of the factors that contributes to that. So clinical depression. So again, I'm stressing here that we're talking about it, again, not the normal sense of being a bit depressed, not the normal reaction that a person might have to something bad happening in their life that lasts for maybe a day or two or very short time, fleeting. I'm talking about a pervasive sense of depression. That the figure there, in older people, of course, are going to more likely get that Parkinsonian stoop posture type of depression, the melancholic style. So that's where the stoop posture comes in, subcortical aspects of the disorder for the more severe types of depression, which I'll talk a bit about later. So again, as with anxiety, physical and psychological symptoms, weight loss, pains for physical, for example, and often the pains are hard to get to the root of what's actually going on. Various types of chronic pains that can be in various parts of the body. It may be related to a specific injury that's happened some time ago, but frequently we see people whose pains are all over the place, if you like. And for it to be more significant as a clinical depression, we'd like to see persistence for at least a couple of weeks. When it's a lot less than that, it's questionable as to how much you regard that as a clinical depression at that stage. So this is that study I mentioned before, where we looked at combined anxiety, depression. We also looked at how common depression was in general practice. So we had over 22,000, as you can see, general practice patients. That was a reasonable sized study, 60 and over. And basically the age-adjusted rate of clinical significant depression was 8.2%. That's approximately how many of your patients in the old age are clinically depressed. And with males, slightly higher than females. In terms of major depression, that is the more severe types of depression, it was obviously much lower, 1.8%. So it's quite common, a bit higher than the national surveys would show. And that's because every survey that I'm aware of around the world that's tried to look at depression across the entire age range has tended to undercount depression in late life. When you look at studies that only look at older people and the methodologies are set up to capture that information more accurately, the numbers are higher. And this is the can we ask about it later? Yeah, can we come back to it? Or then we'll have the question and answer later. Yeah, you can store up your question. So where depression is common tells you a lot about depression in late life. If you look at where people are physically sick, that's where depression is very common. In medical hospitals, in residential aged care, in outpatient medical clinics. Depression rates are much higher with medical health comorbidity, because that's the main driver of depression in late life, apart from the social factors. And of course, we know that with both anxiety and depression, there are a lot of negative outcomes. Quality of life issues, suffering issues. burden issues on family, society, economic issues. I was at a meeting the other day where somebody pointed out that nobody really measures the burden on society of depressed older people who are no longer able to do their voluntary work, looking after grandchildren, doing the myriad other tasks that older people volunteer for. That economic burden that happens with depressed older people is hardly ever measured, but it's there. And we need to be aware that those kind of burdens that are happening. Obviously, health service use, people go to their GP much more frequently if they're depressed. They may not be going there and saying to you, I'm depressed, that's the reason I'm coming to see you, but they go. And anxious people, the same. They will turn up in your practice, they'll have a variety of reasons that they'll be there, and not all of them will have much to do with what they would identify initially as their mental health. You'll probably see it as being mental health, but they may not see it that way. And there's often a bit of a disconnect that happens, and it's often one of the challenges, I guess, in general practice, how you get the patient to see, well, the reason you're here really is because you're feeling isolated, anxious and lonely, type of thing. And how can we work on that? Whereas a patient might think it's got something to do with their pain in their knee or something. I'm sure I'm telling you things that you see every day. And of course, more depressed people are more likely to end up in residential aged care. I've often said that the only patients I know who want to go to residential aged care are depressed. If a person says they want to go to residential aged care, the first thing you should think of is this person depressed? And that's not just because of all this stuff that's happening with the Royal Commission. This is what has been apparent for many, many years. Depressed people usually want to be, are the ones who ask you to go to aged care. And of course, suicide risk, mainly with depression, but there's some level of risk with anxiety too. So how common, how strong is the relationship between depression and suicide in late life? Well, this was work that I did a few years ago, where I just got all the studies that have been looked at, both suicide in late life and also suicide attempts in late life. And I combined the data of how common was depression in these studies. You can see with the suicide studies, about 2/3 of people who die by suicide, where somebody's really looked at what was happening in their mental health, 2/3 were depressed at the time they died. 1/3 weren't, but 2/3. So it's a big contributing factor. And in terms of self-harm, very similar. And it depends on how you look at the study. Some studies had 100% because they only looked at the depressed people who self-harmed. But probably, if you took in everybody in, at least 2/3 would be clinically depressed at the time they self-harmed. So it's a big driver of all this. Now, having said that, I really want to stress that getting behind why the person's depressed is really important. And that's clearly, it comes into a lot of social factors and medical factors and family factors and psychological factors. But the end point is the depression is what's driving the last act, if you like. This is the most recent data. This is preliminary data from 2017. And just to stress why in Tasmania, the older persons are of concern, and you can see at the end of life, especially over the age of 80, there's a peak in males of suicide. And you can see there's also a peak there in midlife. And for those of you who are about my age or a tad younger, will remember the youth suicide crisis of the early 90s. Remember that? There was a huge, terrible increase in suicide in people in their teens, early 20s. They're now in their 40s and they're still got high peaks of suicide. This is what we call a cohort effect. The cohort who were teenagers and in their early 20s, in the early 90s, early to mid 90s, have every year, every cohort, as they've grown older, have had a peak of suicide. So the sociological effects of suicide are very clearly an element of why that's happening. Of course, in 20 or 30 years' time, they'll be older. So who knows what those numbers will look like unless we can make some other big differences. So what are the risk factors? Well, I've put together depression, anxiety, and suicide in the one slide for risk factors for a good reason. Because although they're different phenomenology, they have overlaps of issues. And a lot of those overlaps are captured here. And I stress the physical health I've already mentioned. Really, any type of physical health, any way it's measured, increases your risk of depression, anxiety, and suicide. Whether you're looking at quantity, whether you're looking at severity, but of the types of disorders, neurological are the main ones. You know, if you had to pick up type neurological, cerebrovascular disease is a big factor in terms of late life depression in particular, and of course cardiac disease, cancer. Each of these will have an effect. But diseases that affect the brain is where most of the change happens. And one of the things that we're increasingly seeing, and I'm increasingly in my research been looking into, is the early cognitive changes that happen with people. They don't have dementia, but they might have early stages of mild cognitive impairment due to cerebrovascular or neurodegenerative changes. And I think there's more and more that we're seeing that's one of the things that happens. You know, have you ever asked yourself the question, why has my 75-year-old patient become depressed now? There's nothing happening in their life. There's no big psychological issues here, but they've just become depressed. Their health seems okay. It's probably brain changes. It's probably brain changes either from an early stage of neurodegeneration or from cerebrovascular disease. A nice study that's come out of Taiwan in the last couple of years looked at older people who self-harmed, who did not have dementia, and followed them up over 5-10 years. And their risk of developing dementia was much higher than other people who didn't self-harm when it corrected for all the confounding factors. And I think this is one of the things that we're realising, that your self-harming patient in late life who's never had maybe mental health history before or had other reasons to self-harm before, it may be your warning sign is a cognitive disorder group. I think that's one of the futures that we'll be looking into. Disability. So all those physical illness things are important, but it's how you deal with the physical illness and how it affects you. If you become socially isolated, if you become dependent on people, if you are in chronic pain, all of those factors will have a huge impact of how you deal with these. And more, you might get more depressed. You may not become suicidal. Not everybody becomes suicidal. Most depressed people don't become suicidal, but some do. And some of those, I think some of those cognitive factors are part of why some do. Social isolation and loneliness, I can't stress how important this is. This is such a huge issue across that whole domain. And it may be the person becomes that way because family have died and they can't get out, they can't drive a car anymore, or you know, all of those other factors. But becoming isolated, becoming lonely. So isolation is sort of an objective observation. Loneliness is a subjective feeling, okay? So they're sort of similar, but they're different. So, you know, you can be lonely and sitting in a room of 100 people, if that's how you feel. If you don't have, if the people around you or the people you're meeting with aren't meeting your intimate needs. But being isolated, some people who can live alone and be perfectly happy, perfectly content, but others get very lonely. So there's a huge overlap, but they're not precisely the same. As you get older, you know, your relationships don't necessarily improve, And of course, you might be the victim of elder abuse. You might be an ongoing victim of domestic violence. You might have problems with your children. All these things happen. So relationship issues continue to have a role in all of these factors. Childhood adversity. Yeah, what you've grown up with still has an impact late life. You might be fortunate to be resilient and have gone through life and coped with life perfectly well. And one of the areas where we've seen this come out as being an issue is Holocaust survivors. We had numerous Holocaust survivors. Part of Sydney I work in is eastern suburbs of Sydney, where the biggest Jewish population of Sydney resides. So we've seen time and time again Holocaust survivors who not had a mental health history, who in late life, as other issues start happening, their health declines, their other family die off, etc., become depressed, anxious, and suicidal. So the earlier traumas come through. So, and we've certainly published work both with Aboriginals and Australians, and in that general practice study I mentioned, showing that people who are survivors of childhood sexual, physical assault abuse are much more likely in late life to have mental health problems. Accommodation, people in poor quality accommodation, threatening to go to a nursing home is a huge issue. It makes people anxious, depressed, and suicidal. And of course, being in a nursing home. The only thing about being in a nursing home that's protective against suicide is that you're really getting rid of a lot of the means. There's still suicides happen in nursing homes, but protecting, you sort of, in a way, you make it less likely to happen. But the unhappiness of nursing home residents is legendary. There are not many people who live in nursing homes who are happy about being there. Many of them are frankly clinically depressed. And that's something it's a burden that we all have to work out how we can do that better. I'm certainly not suggesting that there shouldn't be nursing homes. I'm certainly not suggesting that things can't be done to improve that, because I'm sure things can be done. But we always have to take in mind that the person who's there is not usually happy to be there. And that's something we have to work with to try to improve it. Obviously, financial concerns across the age range. Substance misuse. Those of you who are earlier in your careers are going to see a new generation of older people. Us baby boomers like our grog, and we like the illicit drugs too. And that combination with chronic pain, with suicidality and depression is mighty huge. And in fact, we're starting a whole heap of research on this at the moment, where we're looking at that combination. So you've got a new generation. Baby boomers drink more. They've used more illicit drugs, and they continue to use those drugs. They're a different brand to previous generations. They're only 5 years into being old now, and you've got another 15 years of them to come. And when they really get old, that is, at the moment, their oldest baby boomer is only about 70. When they really get old, into their 80s, boy, that might be interesting. So you need to be aware that substance misuse is going to become a bigger issue for your older patients, and with the effects on mental health. Medication, obviously all the drugs we use, and of course hereditary, still genetic effects that persist into late life, but less so than in younger people, of course. Well, how can you prevent? Well, yes. I mean, looking after your health when you're younger makes a huge difference. Being able to educate yourself. The same, if any of you have been to any of the presentations that some of my colleagues have given about preventing dementia, my friend Henry Bedardi gives a lot of talks in this area, many others do too. It's the same with this. Because really, to improve your mental and cognitive health in late life, you've got to start looking after your health earlier in life. And that means mental stimulation, physical exercise, mental social activities, relationships, friendships, etc. All of these things are really important. And so we can try to deal with things when they become isolated and and so forth. But if we want to prevent, you've got to start earlier. So how do you prevent? Well, in my field, I used to do it because I'd see older patients. I'd be talking to the children who are bringing their parents along and saying, well, this is what you need to do if you don't want to get here. They often ask, what can I do to prevent me getting like my mum or dad? Okay. So you give that talk. Obviously, if you've got patients across the age range, you can focus on those. Add that to your list of why you should look after your health when you're younger. So there are many ways, contexts where you can screen for anxiety and depression. And obviously the GP visit, ED visit, many other ACAT assessments if people are having ACAT. So all of these are places and a screen could occur. And how frequently they should occur may depend on the patient or the context of why the person's seeing you. But some of these contexts, like entering a nursing home, for example, would be automatic. And ACAT assessment should be automatic, that every time they have an ACAT, and these are very uncommon events relatively. But a GP visit is going to happen regularly, so you'd have to work out how frequently you do that. In terms of what I saw, I think one recommendation from a primary health perspective that I saw was about an annual check. I might be wrong there, but and any other situation that you thought was necessary. There are a lot of screening tools, and I've just put a few up here. And the DAS21, the one on the far left, depression anxiety, covers anxiety and depression quite well. We use that in our research more. The middle one is a geriatric depression scale. We use that both in research and clinically, but that's only really depression. That's a short version. It's a 15-item version, so it's very easily done. Self-report. They're both self-report. And the Kessler psychological distress scale, we use that regularly, and it's the instrument that mental health services across Australia have to use. And it's a 10-item distress scale. And it's actually quite good, quite sensitive to people who are distressed. And if they come up positive, that's when you do your more detailed examination. It doesn't give you a diagnosis, it's just telling you people are distressed. So if you do screen for anything, it doesn't matter if it's talking about depression, anxiety here, but you could be screening for some form of cancer or whatever. It's what you do next that counts. There's no point screening and they're just saying, oh, I just screened 100 patients this last week and 30 are depressed, and what you do with those 30. So you need to work out your process. And there's a whole range of processes that might work. So it might be for you as a GP to do more detailed assessment if others are screening to send the patient to you. So we usually would say to an ACAT team, for example, if they screened positive for depression or anxiety, get them to see their GP. Get that be the next step. And so each level of a screening process obviously leads to more detailed examination. But the key is, and the thing that we do wrong in screening for anything is not having a next step that's reliably done. That's really one of the big problems in health. Whoops, what have I done there? Okay. So in terms of assessment, depression workups need consideration of medical, psychological and social issues. And if you think the person has a first episode major depression, never been depressed before, and it looks like symptoms are consistent with major depression, you really got to think that this person needs to be investigated like a dementia case. And in fact, you're more likely to find a reversible medical cause for this case than you will for any dementia case, because depressions are more likely to be earlier in the timeline, if you like, of change related to function. So all the range of blood tests, we would recommend for first episode major depression, I stress first episode major depression, that people need a CT scan as a benefit. Because, we turn up tumours all the time. even at secondary specialist level. So, it's a whole range of things that can come through with that need other treatments. Okay, and it's really something that, sure, it won't be a large proportion of your cases or have something like a tumour, but there'll be enough to justify doing it for that group of patients. There's a lot of factors that hinder diagnosis, of course. Atypical presentations, be it they physical, somatic or behavioural. Fact that a person might see you because they say they can't sleep or in pain or just feel a bit anxious. Older people don't interpret their symptoms as much as a psychological problem as younger people do. They might turn up with the same symptoms. The younger person will connect it with their psychological health, whereas an older person is less likely to do that and lead you in different directions. Very easy, I'm sure you'll agree, if a 30-year-old person comes to see you and says, "Doctor, I'm depressed," for you to say, "Oh, well, let's look into depression." But if your patient comes along and talks about something totally different, but maybe has a few symptoms there, makes it harder because you've got lots of other things to sort through. So it gets much more complicated. So that's why we realise that depression late life tends to be a bit more complicated. And unfortunately, there's a degree of ageism that people are mistakenly believe that it's normal to be old and depressed, when in fact, in late life, depression is you're least likely to be depressed. If you're healthy in late life, your chance of depression is very low. Centenarians, when asked, when was the best time of your life and you were happiest and feeling great best? And what they said was age 70. So most of you in this room, if not all, have got the best years to come. And I think that's something to be aware of. So if your older patients start, who you've never known to be depressed before in particular, I mean, obviously the ones you've known to be depressed, well, that's you're aware of their risk. But if they've never been depressed before and start saying they're feeling depressed and they're getting old, it's not because they're older. There's something going on here that's clinically significant. And I've talked about how depression cognition overlaps, and it's common for this to happen, and that it could be depression could be the primary disorder, early cognitive change could be the primary disorder, and some patients will see you because they're worried about their memory, and others about their mood, and sometimes it can be accurate sometimes what the person feels is the problem, but it doesn't always work out that way. So you have to be aware they're comorbid in a lot of people. Most people who've mild cognitive change have depressive symptoms. From the age of 40 onwards, depression causes cognitive disturbance. From the age of 40 onwards, measurable cognitive disturbance. So they're going to happen together. Treatment, these are the standard treatments. And in terms of psychotherapy, cognitive behaviour therapy is probably the most well-researched and evidence-based treatment that we have. And hopefully all of you know that you can access online cognitive behaviour therapy for your patients for free. You're all aware of that, I hope? Yeah. Now, at the moment, all the CBT that's available, certainly in Australia, that's free or that's out there is for younger people. So we're actually developing through Macquarie University, who I'm collaborating with some research, a program for older people that should be available later this year. When it's available, I'll send the information to the PHN and they can send you the details of the program. But these courses are very effective for your mild to moderate depressed patient. And I strongly urge, this is the sort of places that you start. So the counselling, the psychotherapy, it's hard. Obviously, you send them to see face-to-face psychologists. I'm not against that at all, but they're hard to access. It's hard to access in Sydney, in the eastern suburbs, where there are psychologists that, falling out of the trees. And if we have trouble accessing them there, I can imagine it must be much harder in Tasmania. It's just that they're hard to get, particularly those who know well how to treat older people. Pleasurable activities, exercise, get physically exercise is very important, and obviously the social connection is hugely important. So step care programs. So this is the sort of research we're doing at the moment, and that's basically that the first line of treatment is a low intensity form of CBT. And so we're doing this in research currently, where we're looking at either a telephone-based or in the next few months an internet-based program to treat the first line of people who have mild to moderate anxiety or depression in late life. And we expect at least 50% will recover without having to see a face-to-face therapist. We'll see. That's our expectation based upon what happens in younger people who've done the same types of program. Antidepressants, obviously, that's the next line for patients. The SSRIs are where we usually start in older people because they're just more tolerable, not because they're better. They're more tolerable for most older people, even though they've got myriad side effects themselves. And the two main agents we use are citalopram and sertraline because they're shorter acting, have less P450 interactions with their metabolites. And there's a bit more evidence for those drugs with older people, probably because they've been chosen because of these side effect profiles in the research. They may not work as well in more severe depressions, such as these features of more severe depressions, where we've got melancholic features on the left and psychotic features on the right, and these can occur comorbidly or separately, but they tend to occur together. So melancholic features of depression really start to indicate to you that you really need probably an antidepressant medication, at least with that patient. Once you start getting a more of a melancholic feel to it, with the loss of pleasure in almost all activities, and I won't read through that list, it's there in front of you. Or when you get into psychotic depression with mood, congruent delusions, hallucinations. So just to remind you that the delusions related to mood in late life don't necessarily sound like delusions. Does anybody know what the most common delusion is for a woman to have in late life depression? I tell you, I've got no clothes. Most women will say to you, I've got no clothes anyway, but they really mean they've got no clothes when you can sit them in front of a wardrobe full of hundreds of dresses or whatever, and they still say, I've got no clothes. Men, I've got no money. And you can show them their bank accounts full of whatever, and they still will be deluded. So without knowing whether or not they do have clothes or money, doesn't sound like a delusion, but that's the key here, is that often the delusions in late life severe mood disorders don't necessarily sound like. Of course they can. It can be the patient tells you they've got a cancer and you know full well they don't have a cancer, and so forth. But and delusions of extreme positivity where they tell you that they have no money at all when you know it's pretty obvious that they have some. But beyond that, it can be a little bit more difficult. So as I said, very severe depression, SSRIs might not work. And so this is where we get into the other antidepressants, in terms of the SNRIs, the dual action antidepressants, and even sometimes into the tricyclic antidepressants. And we might need to augment. And the most common drug we use to augment an antidepressant is lithium. It's the one that's got best evidence to work. Probably the most common one used in practice, though, is an atypical antipsychotic. And not that the evidence is better, but that I think people seem more comfortable using that for some reason. In my practice, we tend to use lithium as our main. We use the antipsychotics if they're psychotically depressed, of course. When you've got a psychosis and depression, we combine the two. And of course, ECT ultimately is the most effective treatment that we have. And so those patients who have passed through one or two of these rungs or are so severely impaired to start with that they just can't function, we go to ECT, and it's still the most effective treatment for severe depression. So that's the conclusions based on what we were saying a bit before. And to sort of segue into the question and answer part, where hopefully we can take your question at the back there, if you remembered it. I'm going to do a case study to get you started. So this is basically Matt is a 78-year-old man, married, no mental health history, has unexplained symptoms of fatigue, generalised vague muscular aches, poor appetite, and unsettled sleep over a couple of months. Medical history includes hypertension, is well controlled with irbesartan, type 2 diabetes, controlled with metformin, and has ischemic heart disease, had stents 5 years ago. You've done a full physical exam, it's normal. You've done a basic blood workup, nothing comes through. And you decide to explore the possibility that this is depression. But Matt denies that he feels depressed or has any worries beyond these physical symptoms. So, where to now? So we'll get you started. So anybody who wants to start, what we're going to do is have a roving mic. So anybody who's brave enough to speak up and speak into the mic, because then everybody can hear. And then we'll, after we had gone through this, we'll start going to some Q's and A's or some explanations. So anybody like to start? Yep, we've got a volunteer.
So my question would be to Matt, what are these physical symptoms stopping you from doing?
Yeah, so finding out what change in function has happened related to these symptoms. Yeah, that's an important question to get a handle on. What else beyond change of function? I mean, how? So you know, Mr. Matt might say to you, "Look, I haven't been able to go up the shots for the last month, and I'm losing weight, and I'm really unhappy. I don't like that." So, what might you say is, well, how does that affect you? How does that affect your enjoyment in life? Because in this situation where a person doesn't feel depressed, non-dysphoric depression, which means people who are depressed without feeling depressed, can affect the way you get depression diagnosis in this cohort of people, which happens much more likely in late life, is that their pleasure in life is diminished. They're no longer enjoying life. So they might quite openly say to you, "Look, I'm not enjoying my life because I've got all these physical aches and pains." But to get a depression diagnosis, you need to basically have this impact upon either mood, sense of depression, or basically lack of pleasure in life, not enjoying life, lack of pleasure, anhedonia. One or the other. If you don't have one of those, it's hard to get a depression diagnosis. But usually this group of people will tell you that because of all these physical symptoms, because they can't function like they want to, they're not enjoying life anymore. And that's the opening the door into depression. So the next step really in this, as in any other case, is to firm up the diagnosis. Make sure that you've got sufficient evidence from the symptoms to justify you going the depression route. Because it's still possible, of course, that this person's got some other medical problem, even though those basic examinations haven't shown up anything. Remember, we're still at that open stage of working out what's going on. Anybody got any other questions about that case or that kind of scenario with that case? Yeah.
At what point would you, At what point would you start to employ those screening techniques? Would you wait until more medical explanations have been
No,
firmed
do
up?
it straight away. Yeah.
Okay, cool.
Yeah, I mean, try to do everything happening, not in series, but in parallel. I think in late life, the in-series approach to medical diagnosis loses its validity because too many things are happening together. So this man may well be depressed, but he might also have a serious medical problem that's gone beyond these screening tests. I can cite many patients I've seen over the years where that's happened. The most recent one, a woman in her 80s who's never had a depression before, who had all the screening tests done and nothing much comes up, and then was having more and more problems with her bowels, constipation. Anyway, cut a long story short, ended up having peritoneal cancer. Now, that's a very rare cancer, but the point was that this was, it took a while for that bit to come through. The depression was fairly clearly diagnosed quite a few months before, but the other bit, it took a while because the basic bloods were okay, scans. There's nothing else to hang it on at that point. So what I'm trying to say is that you have to take into. I've had many patients who have had multiple morbidities happening that needed treatment. The depression needed treatment, the medical problem or multiple medical problems needed treatment. And that's what we have to be aware of. The older you get, the more likely that in parallel approach to treatment and assessment is necessary.
Are there any more questions in regards to the case study?
Often the shortcuts just get the partner in. And often they just turn up anyway.
Pardon, sorry?
The partner. They turn up.
I think that's really important
They
to try to
turn up,
talk
say
to the
person
partners.
just sitting around doing nothing all day and you don't need to go much further then.
Getting family involvement in the assessment is critical with any older person, be it for their mood or their cognitive, and of course as part of the treatment, as you imply.
Any more questions? Otherwise, I would suggest...
Any other question? We had a question at the back from before.
We'll bring you...
My question was just about that study you did back in 2009 with 22,000 elderly patients, and you said that 8% of them had clinically significant depression.
Yep.
And only 1.8 had major depressive disorder.
Yep.
So how did you decide between the two diagnoses?
Well, major depressive disorder, we used an instrument called the PH9, which is a survey instrument that's been validated across the various countries, which has all the symptoms on it that's equivalent to major depression, and with all the riders about how long you have the symptoms, etc., etc. So everybody who within that instrument who met all the criteria that were required for major depression, that's got that. But people could have lesser symptoms than required for major depression, and still be depressed. And so that's how the number. And of course, a lot of people had lesser numbers of symptoms.
That clinically significant depression was based on a K10 score or a DAS?
No, based on the PH9.
On the same PH9, but a lower number.
Yeah,
okay.
basically.
So it wasn't a subjective thing; it was actually based on. No, I thought so.
Because they was the part of the instrument talks about how much it affects you. How much do these symptoms affect you? And that's where we got the clinically significant from. These people, it was affecting them in their function and their well-being, even though they may have only had 3 or 4 symptoms instead of the 5 you need for major depression.
I just thought 1.8% was probably sort of lower than I would have expected.
For major depression, no, it's, yeah. I mean, between 1 and 2% is what most of the studies show around the world, 1 to 2% of older people have major depression. Because what we tend to forget that most common depression in older people really is less severe. I mean, in younger people too, is less severe forms of depression, and that's really what the study essentially showed, which is consistent with what other studies have shown. Yeah.
Well, one of the questions I had when I looked at the statistics of the 85 plus male that have significantly higher suicide rates in comparison to the female, can you talk a little bit more about that?
Sure. So, I mean, essentially the highest rates of suicide in most countries around the world have historically been in older males. And up until maybe 20 or 30 years ago, in Australia, 75 was probably more the cut. It's got a bit older, in fact. And we tend to think that what's sort of happening in a lot of older men is that we're talking about often men who are single, either divorced or widowed or never married, whose health starting to fall apart and who are not coping with their social situation at the same time. And I think what seems to be the case is that women seem to cope better with that scenario than men. For whatever reason, women seem to cope with this level of adversity better. And if they do self-harm, and they self-harm at about the same rate as men. So in terms of self-harm, rates are no different between men and women in late life. But men will use much more lethal methods than women. They will certainly more likely to hang themselves or use carbon monoxide poisoning. Women are more likely to take overdoses. And it kind of evens it out in a sense. So for men, a sense of worthlessness, sense of what's the point of going on types of issues seem to come through. And that seems to happen, as I said, it seems to be getting a bit older because I think the kind of factors that lead to it, men, these days, older men and older women are in better health than they ever used to be. It's hard to realise, that the 65-year-old, when I started medicine, was not a very healthy 65-year-old on average. Much more like our 75 and 80-year-olds now. I mean, we underestimate how much health has improved in older people. And although there's longer period of disability, much of that disability is livable disability, not unlivable disability. It's not necessarily pleasant for some people. So we actually have come a long way. But and that is reflected in suicide rates in the I'll go back to this slide about suicide. And you can see that dip that happens in around 65. That dip's getting lower and lower. 65-year-olds are much healthier than they ever used to be. And doing things, and don't feel old. I mean, if you talk to an average 65-year-old and say, oh, well, you've got to go to the geriatric ward or something, they look at you and think that you're being rather rude. Being 65 myself, that's how I feel. But the point I'm making is that wasn't the case when I started medicine. 65-year-old was truly old. 65 is just an age of that's been chosen by society as when the pensions used to start. That's how it became defined as old age. It's just the pension age. It depends on the country and all that. So anyway, I think it's that's the main factor. Yeah.
I just wanted to ask, suicide prevention wise, what does a safety plan look like in elderly men?
What does what? Sorry.
Like a safety plan for elderly Australians.
Yeah.
What does that look like?
Well, it looks like basically when you're talking with your patient, and you sit down and work through with the patient. So your patient you assessed as having some level of suicide risk. Okay, whatever's going on, and so a safety plan is, well, how can I feel confident, and the family, the patient feel confident that in the next week or so, next few days to a week, really it's only a short-term plan, safety plan. What happens in the short term? Because that's really as far ahead as we can reasonably predict with anybody, and even that's a little bit iffy. But so it's a short-term plan. So can you feel confident that this person A is going to comply with whatever treatment that you want to start? B, do they have the necessary social supports that are competent to support this person in that period? Are there any medical or issues, for example, that need to be treated that the person may not comply with that will adversely affect that person? Are there means to harm themselves that need to be removed from that person's access? So, if you're talking about rural Tasmania, they might have guns. They got gun access. And if they have guns, where are they? Has that issue been addressed? If there's medications, are there medications in a blister pack with a distinct smaller amount of meds that are available? Obviously, there are some aspects of safety that you can't really totally address. But having supervision will account for some of that. So obviously, you don't want a person to have access to sharp implements, especially if they've been thinking that way. Now, if you based on all of that, if you feel you don't have a family or friend support network that can provide that short-term support, or the person's not going to comply with whatever treatment for either the mental health or the medical or both aspects of their problems, or they have no insight into what's this whole thing, and their understanding of what's going on is limited, or they won't comply with some form of means restriction, then you don't have a safety plan that's workable. That's when really that person probably needs to be in hospital. But if you can put together a process where those issues are addressed with family and friends and health services, or mental health services, of course, but all of that, then that person's likely to be manageable at home in the short term. So that has to be continuously reassessed, because our safety plans can only operate for a very short time. Our prediction of risk is very short period, 24, 48, 72 hours, sort of that sort of time frame, and then it has to be reassessed.
Any more questions? Yep.
A lot more people over 85 are driving motor vehicles now. Is there much data on how much suicide is used by motor vehicle?
It's very hard. It's very hard to know how much. I mean, this is when you look at accidental deaths, undetermined deaths, and so forth, how many of those in Australia could be pushed into the suicide column? It's not that many, but there would be some. Other countries maybe more so, because in other countries they're a little bit more likely to put the suicides into an accidental or undetermined death than we are in Australia. But it's very hard. I mean, when we did one of our studies, when we looked at suicide in middle-aged and older people, and we compared them with people who died accidentally or by some other natural cause, suddenly, unexpectedly, if you like. We excluded anybody who was in a car who was driving alone at the time of a death. So in other words, single person motor vehicle accidents, we said, no, they can't be our comparison group because they could have been a suicide. We don't know. We had no evidence to say they were. But you really don't know. Unless a person has very openly written a suicide note and that's discovered, but who knows? I think in older people, probably very low. I think this is a more of an issue in the young and middle-aged people, especially fueled by drugs and alcohol. I think that may be a more common scenario than in the very old. The average 85-year-old isn't driving too far.
And Tasmanian data actually shows that medication overdoses is often used as a mean.
Sorry, medication?
Medication overdoses is often used as a mean to end life.
In Tasmania, or generally? It's not a common. The two big ones are carbon monoxide and hanging. Medication overdose happens more likely in a woman than a man, but it's only a relatively small proportion of total suicides in late life. You know, relatively speaking, I think we're talking. I mean, people survive these days. That's one aspect of it. That some of the drugs are not as toxic as they used to be, or the really toxic ones, people aren't aware how toxic they are and don't take them, which is good. But generally, resuscitation now in major hospitals is just way ahead of what it ever used to be. You know, with paramedics and then hospitals, it's just totally different ball game to what it was 30 or 40, 50 years ago, where people would die because they just weren't being well treated in the resuscitation stage.
Are you aware of any research that's happening now, given Victoria's euthanasia laws, comparison rates of suicide among older Australians in Victoria versus other states of Australia?
So the gist of the question is, so I'm aware of any other states that are going that way, or...
No, are you aware of any research that is actually happening right now where they're looking at figures of suicide in older Australians around the states of Australia versus what's happening in Victoria?
Not that I'm aware of. There might be in Victoria, some of the researchers there, but I guess as far as I can tell, the overlap between suicide and euthanasia is a relatively small one. It's about maybe 5% of older suicides might be otherwise reclassified as euthanasia. That's what the best evidence seems to suggest. Maybe 5, maybe 10% at the most, but in that range anyway. So we're talking about an overlap, but not a huge overlap, and they are quite different phenomena. As to anybody actually doing anywhere in the world good quality research to look at the impact of law changes and suicide rates, etc., I'm not aware of any good quality research being done on that. And it begs the question, it needs to be done. We've certainly got a paper that looks at, that hasn't been published yet, but it looks at older people's views about euthanasia in late life, as opposed to general population views, but older people's views. And as one would expect, older people are much less in favour of euthanasia than younger people. It changes. It really does. But the actual research into seeing what impact law changes might have upon suicide and suicide rates, nobody's done that. I've had one patient a year or two ago who was very active in New South Wales in trying to get euthanasia laws up in New South Wales. They just missed out by a few votes a couple of years ago. And she was an active campaigner. She also had terminal cancer, and she also got seriously depressed. And in her serious depression, in her terminal cancer, with probably no more than 6 to 12 months to live, she became quite suicidal, very suicidal, which responded, got better with treating her depression. And in fact, by the time I saw her, she was already a lot better. Her GP had already got the treatment going with the palliative care services. But I had a long talk with her about all these issues. And what was very interesting was that she could articulate to me that how she felt with being suicidal was not how she felt with euthanasia. that was completely different, that the criteria that she had very clear in her mind about when she wanted to end her life, she still held those ideas, were not met by how she felt. She said, I was depressed and suicidal. It wasn't when I wanted to end my life. That's why I wanted to be treated. And she was, so she was one of the most articulate people I've ever spoken with, who could actually work through in her own mind about herself what the differences were. But the factors that led to the depression were very similar to the factors that would contribute to euthanasia. So the factors are very similar, they're overlapping, but for the individual, it was quite different. So that's why I think there's only a relatively small overlap, but there is an overlap, and we need to be aware of that. The other thing about suicide prevention in older people that I've certainly, when I have been involved in not social media, but online conversation type pieces about suicide prevention in older people, get a few people write in and say, well, you're basically against the older person's rights to die, etc., which of course is a load of nonsense, because I think anybody has the right to euthanasia if that's what they believe. It's suicide prevention in older people is not against the person's right to die. It's about giving the person the right to live when they don't necessarily want to die. And I think that we need to be very careful with that, even though the factors are going to be very similar. And so you can help people, as I helped that woman, and didn't alter one iota her desire to have euthanasia when she got to it. Her big complaint to me was that palliative care didn't see it that way. So sometimes palliative care get very uneasy about this euthanasia business, and it's and she felt that they were very uncomfortable with that idea. I don't know. That's what she told me. I do work with palliative care, but I've not noticed that problem myself personally.
Any more questions? Otherwise, I would say we wrap up.
Whenever. If no more questions, we can all have we've had your desserts and coffee. I'll have my dessert and coffee. Okay.
Well, thank you very much for attending tonight. Hopefully you enjoyed your meal. Hopefully you enjoyed the presentation of Professor Draper. He has done an excellent job to bring this topic a little bit closer to where we are at, I guess, in our practice. And we also would like to thank him for doing a massive tour for almost a week around the northern part of Tasmania, talking to other groups. And tomorrow we do have the Launceston City Council, who is hosting community organisations. And Professor Draper will talk to community organisations about suicide prevention in later life. I would also like to let you know that tonight's session was recorded, obviously, and will be available on our website soon. We will let you know when this is available. So hopefully others that could not attend tonight will be able to benefit from tonight's session. That's it from me, I believe. Thank you very much, Professor Draper.